Assalamu alaikum and welcome. After a long time, I'm making a little video on the clinical subjects. We all know right now, towards the end of April, we are in the throes of Covid-19. Yes, the skies are clearer. I'm sitting in my side yard enjoying beautiful breeze right after the rain. Gives us more time to spend with the family and to catch up on a bit of rest and alone time. At the same time, we have patients who relied upon us and who still rely upon us to take care of their dental needs. One of the worst things that can happen to a patient is to have toothache, or in certain cases, that toothache can lead to life-threatening infection or the spread of infection. As we know, the consensus throughout the world among the dental professionals is that we are at extremely high risk of catching this infection. We are at a much higher risk than the nurses and the physicians directly taking care of those patients who are in need of hospitalization because of this infection. The main reason that we are in that group is because of the aerosol created normally during the treatment rendered in a dental clinic. Hygienists are a little bit at higher risk category than dental surgeons are, but nonetheless they're pretty close. The infection rate is about 92%, 93%. That is a very high rate. Having said that, the best consensus here has been that we need to take care of our patients' pain without doing any treatment and wait till things get better, then we can get them back in and do the treatment. As far as the pain control is concerned, yes, you can have certain concerns in which the patient might be impaired when it comes to their liver function, their cardiac situation, the bleeding times, and complex conditions. First, I will address the patients who are general public, who do not have severe complications with their health. Baseline where you start with for pain control, when the patient calls, I want to find out if it is because of an infection, or infection as far as the bone and soft tissue is concerned, or is just tooth decay. I want to ascertain how long have they known about this condition with the tooth or teeth. A lot of times what is happening now is the patients were diagnosed with the treatment need, but they did not seek the treatment. They let this time pass, and now when the pain is severe, and more than that, when they have time sitting at home and they're thinking about this pain, they come to you and they want the treatment done now. So the postponement of the treatment was squarely lying on the patient's shoulders. Okay, that has happened. And now we are in the throes of the pain. So what we want to start out with is normally paracetamol. In case they are having transient infection, which the patient would tell you that, yes, I did get infected in the past, the face swelled up a little bit, or the jaw area swelled up, or I had some pus discharge, I took some antibiotics either on my own or somebody prescribed it, I never went back for the treatment. You can repeat the same now in this situation. Normally, I would not advise antibiotics. I would go ahead and call the patient in, take care of the infection and treat the cause. And then as a second thought, in case the infection is severe, put them on suitable antibiotics for a day or two, or maximum 3 days, and that's what I would do. But in this case, paracetamol 500 milligrams 3 times a day for pain would be something as a good starting point, and that's what I've been doing with my patients. And I would tell them, please take this and let me know what happens within 24 hours. If it takes care of the pain, then that's all well and good. If it not, then we can move to the next step. Next step actually would be Nsaid, Non-Steroidal Anti-Inflammatory drugs. And at this time, in this kind of infection which is going around, it is not a very good choice to give Nsaids. But if you have no choice, then you can go towards it, but do not get it to the patients who are actually exposed to it. And people who are exposed to it, who are positive serologically, they would need further treatment regardless, or hospitalization. Second line of defense for pain control would be Naproxen. Ibuprofen really does not provide much of a cover. So Naproxen sodium, 400 milligrams, 2 or 3 times a day. 400 milligram would be mostly United States, but I think in Pakistan it's about 500 milligrams. So you can start out with 250 milligrams 4 times a day, and you can pair it with paracetamol, also 500 milligrams 3 times a day, and see if that takes the patient over the edge. And you would want to follow this regimen for 2 or 3 days. You cannot continue this on for months. That has to be explained to the patient. A lot of times in 2 or 3 days, they get over it, and the acute episode of pain is behind the patients, and then they can continue on without the pain medication. I would call them, that's what I do every day myself, to check how they're doing, and normally they improve. In case this does not help, the third line of defense that we have is to discontinue the first two, which is paracetamol and naproxen sodium, and you go to celecoxib. Celecoxib 200 milligrams twice a day. That should kill the pain fairly rapidly, and it's a very strong pain medication. In case that does not work, we can go to the next line of defense, which is Diclofenac sodium injection. Tablets can be given, but they're very hard on the stomach. And if you wanted to give tablets, you can give 50 milligram Diclofenac sodium tablet 3 times a day instead of the other 2 medications, and that should help the patient. And I'm giving you these medications in the level of intensity. So first one was paracetamol to start with, then naproxen with it. The third one was naproxen and paracetamol combined, and then we came down to celecoxib, and now we're going up to Diclofenac sodium. After that, of course, you can go to ketorolac. By that time, if the patient is needing those kind of strong pain medications, then the situation is getting worse. Now, in case simultaneously they have an element of infection, then the best medication is the most broad spectrum medication in antibiotics for the oral environment, and that's actually penicillin, PenVK. Unfortunately, PenVK is not available in Pakistan, so the second best medication would be amoxicillin. And amoxicillin works better if it has the enzyme added to it in the form of the new composition augmentin. So augmentin 625 milligram tablet 3 times a day would be suitable for the patient, along with the other medication regimens that I told you in succession of severity. But please tell the patient not to take this more than 3 days. Do get in touch with them every single day to find out how they're doing, and get them appropriate confidence that you are there to take care of them, and then the pain should resolve. Now, during this time or any time, if the patient does tell you that they're having difficulty in breathing, if the eyes are shut closed, or if they feel swelling coming down towards the neck, then that means that the infection is getting worse, and it could turn towards Ludwig's angina or possible infection of the cavernous sinus. Then they would need to be taken to hospital and be hospitalized. A general dentist should not be taking care of that kind of infection. The patient needs to be put on IV antibiotics. The patient needs to possibly have the airway management done by people who are specially trained in taking care of this. I hope this helps you. It's a simple formula. It's a simple little table, and that's what has been working successfully with me for the last month and a half approximately. I had shut down normal patient contact since March 2nd this year, and today is April 18th. So I've come along this time, this long, taking care of patients like this. I hope that helps. Thank you.